네, 안녕하세요. 저는 서울 뿌리 깊은 치과의 조영진 원장입니다.
Greetings, I'm Dr. Jo Young-jin of Seoul Deep Rooted Dental Clinic. Today I want to talk about solitary type overdentures as part of online master course. Solitary type implant overdenture means two implants are not connected and solitary attachments are connected. Magnet, locator, and O-ring attachments are primarily used. Because implants are not connected, there can be pros and cons associated with it, and I want to go into this topic today. We can suggest 5 different treatment plans to fully edentulous patients. First is removable complete denture. Second is implant overdenture, which is the topic of the day. Third, implant-supported FPD and RPD. Fourth, hybrid type, or fixed complete denture. Fifth is implant-supported fixed partial denture, where multiple implants are involved. We need to look at various factors and make examinations, and based on that, we decide upon the treatment option. We need to look at the degree of clinical deficiency, so whether it's teeth only, or whether it involves gingival contour or alveolar process along with it. We need to look at whether deficiencies exist in basal bone. These can be the basis for our decision. We also need to look at interarch distance, type of antagonist, patient's physical and medical condition, and patient's demands, as well as ability to maintain prosthesis hygiene and financial limitations. We need to look at these overall conditions and make a decision as to whether implant overdenture is going to be used or combination or implant-supported fixed partial denture. We need to choose the appropriate treatment option. On the chart, we see fully edentulous case, but in clinical situation, we come across situations where there are multiple residual teeth that require extraction. In situations where extraction has been done not so long ago, then in that case, underlying bone quantity and quality will be comparatively favorable. There can be patients who have been wearing denture for a long time as well. Or there can be a situation where there's a lot of alveolar ridge deficiency, but because there's a bit of residual teeth, and although these teeth might require extraction, there can be a fair amount of bone quantity and bone quality. Because the residual teeth are to be extracted, you can consider these patients fully edentulous as well. All of them are fully edentulous patients, but depending on the situation, we need to make a different decision as to which treatment option is most appropriate. Implant-supported overdenture can be primarily considered for patients who have been fully edentulous for a long period or who will become fully edentulous after extracting the residual teeth.
이런 경우에 주로 우리는 오늘 말씀드릴 임플란트 서포티드 오버덴처를 치료 계획의 최우선순위로 두게 되는 것 같습니다.
Implant-supported overdenture can be considered as a top priority in these cases. When you compare implant-supported overdenture with fixed partial denture, which require more implant placement and complete denture, because a fewer number of implants are placed, implant-supported overdenture is more simple in terms of treatment and it costs less. If you place multiple implants, functionally it may be more favorable, but in terms of maintenance, implant-supported overdenture can become more advantageous. If you look at long-term success rate compared with complete denture, implant-supported overdenture shows higher success rate, and in terms of function, when more implants are placed, it can provide better function, but compared with complete denture, implant-supported overdenture provides better function. Preservation of remaining bone. Implant-supported overdenture shows more favorable conditions compared with complete denture. Implant-supported overdenture can be largely divided into solitary type and bar type. Today, I want to focus on solitary type. The implants are not connected and solitary attachments are added. Locator and ball attachments are most prominent solitary types. If you look at the literature which compares ball attachment with bar type, bar type overdenture shows better retention. But if you think of these days, locator attachments are used more frequently compared with balls. So if you think about locator attachment, retention does not fall compared with bar type.
로케이터 어태치먼트를 대체를 한다면 이 리텐션이 바 타입에 비해서 그렇게 많이 떨어지지 않는다라고 생각을 합니다.
In terms of oral hygiene and simplicity of treatment and cost, rather than fabricating bar type, you can use a Soltary ball type, which can be used independently. It's more simple and treatment can become more easy. O-ring and locator attachment are most frequently used. The biggest difference between the two is the amount of vertical space taken upon the component. The locator attachment, which we use most frequently, the vertical space that it takes is 2.7 millimeters, so it's a very low profile attachment. Compared with O-ring, it can be used in more confined spaces. And because the components that provide retention are color-coded, you can use it more conveniently. Locator attachment is very favorable for maintenance, and once it becomes loose, you can change it very easily. There's male nylon part with different degrees of retention, so if it becomes loose and if the patient wants a stronger retention, we can change it very easily and patient satisfaction can be achieved. More than anything else, this is low-profile abutment which takes up very little vertical dimension, so this can be used even when the interarch distance is limited. That is the biggest benefit. If you look at manual and textbook, in angle situation, even if there is about 40 degrees of deviation because attachment is resilient, you can use it. Physically, it's not impossible, but if you are to use two or multiple solitary type attachments, the path of the multiple implants placed should be parallel or close to parallel in order to get ideal results. Then it'll lead to less wear of component and wear of attachment will be reduced so we can manage it more easily. In 2002, in McGill University, Montreal, Canada, there was a consensus meeting. 22 prominent speakers, including Gunnar Carlson and Rikiston, gathered around and talked about the fully edentulous case in the lower. Various presentations and scientific evidence were produced, and based on the various experiences of the participants, there was a consensus report. The details of the consensus report is that in lower edentulous case, the first choice of treatment should be implant-supported overdenture using 2 implants. In other words, for fully edentulous case in the lower, the first option that we should consider is implant-supported overdenture using 2 implants. This is very predictable and can provide great satisfaction to both the dentist and the patient. Let me share with you a case. This is a 74-year-old female patient, and the patient has been using multiple sets of complete denture for years. Once it becomes loose, the patient received next denture, and the patient has been using it for long. The characteristic of this kind of patient is that posterior area is lost first, so alveolar bone is significantly resorbed in the posterior and it is fairly less resorbed in the anterior area. You can see that there's a bit of bone height in the interior and there's a significant resorption on the panoramic image. The patient came in November 2016. In this case, complete denture will be provided for the upper, and for the lower, implant-supported overdenture using 2 implants. It will be the first choice of treatment. This is the recommended treatment modality. In December 2016, 2 implants were placed in 3 and 3. In the thin ridge expansion was done as well. Secondary surgery was performed, and this is the image of relief within temporary denture. As shown in the lower, when placing 2 implants, as mentioned before, I'm going to talk about it additionally when I talk about bar overdenture, but especially in the case of solitary type implant overdenture, the 2 implants need to be parallel. Also, it needs to have a perpendicular angle to the occlusal plane. This would allow for easier maintenance after treatment. Also, the fabrication process is much more easy. You need to pay a lot of attention to implant placement. At a glance, you may think that it does not necessarily need to be parallel, but that's not true. But the implants need to be parallel, and we need to pay a lot of attention to it. From the midline, the 2 implants need to be apart in similar distances, and if possible, there needs to be symmetry between the 2 implants. If the implants are placed in a deviated manner, there can be early retention loss, and there can be attrition of abutment and attachment. So in implant placement stage, we need to pay a lot of attention so that the 2 implants can be placed in a parallel manner. In order to do this, in the middle of where the 2 implants are going to be placed, in the midline area, I do guide drilling and place a parallel pin first and place the 2 implants in same distances. And the direction can be parallel as well. You think of the teeth alignment, and in the center area, you do 2 millimeters of drilling at parallel pin. And from there, you place implants on both sides with the same amount of distances apart. By doing this, you can place implants in a parallel manner. By doing this, the prosthodontic phase that's going to follow can be much easier. From there, we make a prosthesis after going through a series of prosthodontic steps that are very similar to making removable full denture. Border molding is done and functional impression is done. Teeth alignment is done to get balanced occlusion, and curing, if necessary, clinical remounting or lab remounting is done to address occlusal errors. Various steps that we utilize to fabricate removable prosthesis are utilized for prosthesis fabrication. In the upper, there's full denture, and in the lower, implant-supported overdenture using 2 implants have been planned, and in this case, I actively utilize 0-degree teeth, and depending on the ridge condition, I utilize crossbite actively as well. As you can see, 0-degree teeth are used in the posterior area, and here you can see on one side there's crossbite. The main model is poured, and you do mounting of upper and lower. When you look at the ridge condition before aligning artificial teeth, the relation between the upper and lower, you can see that the upper is narrower than the lower, and this can be observed quite frequently, especially when the patient has been without teeth for long term and has been using full denture for long term. Over 90% of the time, such relations can be observed. If you do teeth alignment following ridge, more so than the lower, the upper becomes narrower and crossbite is formed. You do not need to fear of this. Following the ridge, and just naturally, if you align teeth in crossbite, if you try it a couple of times, you come to think that physiologically, such teeth alignment are more favorable. Crossbite can be actively utilized, and if you utilize 6-degree teeth accordingly, in certain position, the artificial teeth is not locked because it does not have 3-point contact, and teeth alignment can be done within a short period of time because 0-degree teeth are utilized. Vertically, occlusion is good, and you can minimize horizontal stress to alveolar ridge and denture. Also, Even in the case of class 2 or class 3 jaw relation, teeth alignment can be done much easily. Even if there is cross-bite relation, the overjet can be 0.5, 1 millimeter, or 1.5 because there's no cusp and alignment can be made easy. If you look at the disadvantages, the first is poor aesthetics, and there's decreased masticatory efficiency as shown here. On the anterior area, teeth alignment is normal, so it's not a major problem in terms of masticatory efficiency. Compare with teeth with cusp, although it's 0-degree teeth, because you can get sure contact surface. Based on my experience, masticatory function does not go down significantly after teeth alignment. Flusking process is done to complete denture. Once this is done, locator attachments are attached to the implants placed. The dedicated tool is used. After connecting metal housing on the inner surface, you check whether there is any interference, and then it is adapted and treatment becomes concluded. One important thing is after connecting locator abutment and after a series of process, before connecting housing to the inner surface, you have the patient adapt to the denture so that you can check whether there's any sore spot or problems with the function or phonetics. After checking that, you connect metal housing. After you connect metal housing, you need to use a fit checker to check if there is any early contact, premature contact. If there is premature contact, you need to grind that off to provide relief. You need to make sure that denture is completely seated without any holes being punched. After that, the adhesion is done, attachments are connected, spacer is connected here. After that, metal housing is connected to the denture. If there's nothing, or you can utilize nylon nail that is black. For lab purposes, it can be used so that the patient can use it for a certain period of time. If there is no problem, then you can connect the blue nylon cap, which has the weakest retention. If the retention is too weak, you can remove it easily and move on to the next color. So you need to use starting from the product with the lowest retention and gradually increase. This is after prosthesis delivery. You can see on both sides in the posterior area, it's cross-bite. After delivery, just like existing removable prosthesis, you check the surface and occlusion, as well as the border. After about a week to a month, if there is no major problem, in final stage, attachments are connected. After 4 years, for the first time, nylon nail were replaced. On average, people say 1 or 2 years. But if implants have been placed parallel very nicely, then you can use one blue nylon cap for about 3 to 4 years. This is after about 4 years. You can see that there's a bit of recession. The denture itself is nicely maintained, and the patient was very satisfied with the retention and occlusal function. After about 12 years in 2019, after initial delivery at early 2007, I've replaced the nylon cap about 3 to 4 times over the course of 12 years. And after 12 years, although I provided a color which provided a stronger retention, the situation did not improve. In other words, because of time, there was wear on the abutment itself. This is the abutment shape when I first delivered, and this is after 10 years, and you can see that there's a lot of wear. So regardless of how much I replaced the nylon cap, things didn't improve. So I changed the abutment with the same size abutment, and I started off again with the blue nylon cap, which has the weakest retention. This was how it looked after 12 years. The patient continued to use it nicely. So it's been 3 more years, so the patient has been using it for 15 years. Although it being external type implant, of course there's marginal bone loss up to the second thread, but despite recession, the patient continues to use it nicely in terms of function. If you come across implant overdenture patients, because a lot of components are used, it is ideal if you have an organizer where you can organize metal cap, blue nylon nail, or spacer. Maintenance care, just like full denture patient, you need to check whether it requires relining or if the retention is good or if occlusal contact is fine and if the oral hygiene is nicely maintained around the abutment. These kind of factors need to be checked whenever the patient comes. You need to have the patient come in at least once or twice a year. Today I've talked about Soltary implant overdenture. Let me summarize. In full edentulous case in the lower, implant-supported overdenture using 2 implants is the first treatment option that should be considered. Especially in the case of solitary type overdenture, it's very easy and simple. According to various literature, you can get very predictable treatment results. I'm sure a lot of you provide this treatment, but if you have not tried this yet, I strongly recommend you to try it. In terms of retention, support, and stability, it basically upgrades the function of removable denture, and ultimately, this is a treatment option which improves the function to allow patients to chew food properly. What is important here is that although 2 implants are apart, they need to be parallel or as parallel as possible, and the angle should be perpendicular to the occlusal plane. As shown in other cases, this is 1 year, 4 year, 8 year results, and they're nicely maintained. And this can be attested in various cases. Today I've talked about solitary type implant overdenture. Because of time constraint, I was only able to show you 1 or 2 cases, but if you come to offline course, you'll be able to access more details. I look forward to your interest. This is the end of my lecture. Thank you for your attention.
경청해 주셔서 대단히 감사합니다.